The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey there, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I'm returning to the ABC series of topics that I started before I got all distracted with meth madness and the political situation going on right now in the United States. I said on the last episode I was going to do cirrhosis, but then I thought, it's a lot more pertinent to my clinical practice is constipation. My goodness, I did not realize how much constipation I was going to be dealing with in primary care. Same with urinary tract infections. I was not really prepared for how much of that I was going to have to be treating. A while back, I posted on the Knowledgeable Provider Facebook page a little quip about how in my current situation, when somebody comes in with abdominal pain, I just assume they have constipation. And past podcast guest Luke Pike commented something about, I hope not, because you're better than that. And I appreciate the compliment, Luke. And coming from an acute care background, that's exactly what I would have said before, because you never want to be the person who says somebody's constipated and sends them away, and it turns out their bowel's obstructed or their appendix is rupturing or whatever. And I've seen that. One of my patients actually came in with abdominal pain, looking really sick after she had previously been to the ER at one of the small outlying hospitals. And they pretty much did just tell her she was constipated and pat her on the head and send her away. Maybe the only abdominal pain patient that's ever gone to an emergency room and not gotten a CT scan in the past 20 years. But she came into me looking sick, and so I did send her for a CT scan. And it turned out she did have raging appendicitis. I want to say maybe she even ruptured before they were able to get it out. But she got really sick, but she ended up being okay. So I wasn't really being serious. Well, I wasn't being 100% clinically accurate when I said, I assume people now have constipation when they come in with abdominal pain. Because obviously it's important to work through that and go through the differential and not miss the more serious stuff. But man, it is common. And I'll tell you, people do not realize when they're constipated. And I think the reason for that is if there's something coming out occasionally, people don't tend to think constipation. And that's particularly the case when you have constipation with overflow. So you have the situation where the solid becomes so solid and so stuck that the liquid just kind of goes around it. And so a lot of times people will think they actually have diarrhea. I have a patient currently that we're going around and around and around a circle with because they think they have diarrhea and they keep eating Imodium. And we keep saying, it's constipation with overflow. You need to do the opposite. And we're trying to send them to GI and they keep saying, well, they're just going to tell me I'm constipated. Yes, they are. And I can see where that would create a little bit of confusion or a little bit of cognitive dissonance there. Another thing I've seen with overflow is that you'll have leakage. So people will come in, not necessarily because they have liquid stool, but because they are having a little more trouble controlling it, which is always disturbing. So I thought I'd just review constipation in general. The technical definition of constipation means less than 3 bowel movements a week or having difficulty passing stool. So it's not really a disease, and it's one of those things that we talk about as a thing, but it's really a symptom of another thing. On another issue that comes up is people will think they're constipated if they don't poop every day. But you really don't have to poop every day. I think it's always concerning when there's a change in bowel pattern. If someone comes in and says, I pooped every day for 70 years and now suddenly I can't poop at all, or my stool looks really weird, then that's a big red flag. But if the frequency of bowel movements just decreases a bit over time as people's physical activity declines, or maybe their water intake declines, or they get on medication that affects that, a lot of times it's okay. And some people will overdo it with the laxatives trying to make sure that they have a bowel movement every day when that's really not necessary. The change in bowel pattern thing, right when I started with Dr. James, I think I was still doing some shadowing, just kind of getting up to speed and training before I actually started working there. We had a patient come in who said, I've had 4 bowel movements a day for my entire life. That's always been the pattern. And now I'm only having 3. And of course, in the back of my mind, I'm like, okay, whatever you say, buddy. But you know what? He had pancreatic cancer and he was dead very shortly thereafter. That was the presenting symptom. So change in bowel pattern, always a red flag. Anyway, constipation, some underlying issues that can lead to that. You can have problems with transit through the colon, as in the stool's just not moving like it should. That can be a problem with the motility in the wall of the colon itself. There can be a situation where you're absorbing more water from the stool, and so that's making it more firm and harder to move along, more difficult to move along. Or you can have pelvic muscle dysfunction. With motor function specifically, you can separate that into reduced muscle contractions of the colon, so like slow transit constipation, and abnormal evaluation of the rectum. So, like if there's something actually obstructing the rectal outlet, that also falls under motor dysfunction. Pelvic floor dysfunction, of course, that just means that all the muscles that affect the passage of stool and urine kind of don't coordinate as well, or they become weak over time. Pelvic floor physical therapy is a really nice tool for patients who are having bowel and bladder issues. That's a nice alternative to surgery that you can recommend to people for that sort of thing. And I know we're not talking about bladders, but while we're on the subject of pelvic floor physical therapy, please ask your patients with uteruses, people who, especially who have had babies vaginally, about urinary incontinence. I feel like this is something that affects pretty much all women over time, and a lot of them will not say anything about it if you don't ask. And we have several tools, including medications, surgery, and pelvic floor physical therapy that we can offer to people. So make sure you're asking about that. I usually include bowel and bladder within the same area of my annual physicals. There can be neurogenic mechanisms that cause constipation, so you can get situations where the sensory input from the gut going to the brain is not right, and that throws off the bowel situation. Or, of course, stress and psychological factors. One thing that affects kids a lot is just consciously holding it. That's referred to as habitual stool withholding, or functional constipation, or retentive constipation, or functional fecal retention. We love to come up with words in medicine to run circles around things instead of just calling them what they are. That's normally a situation where a kid will consciously try not to defecate because either it's painful or it's embarrassing to them for some reason, or they have some kind of desire for control. And then over time, you get this situation where obviously it leads to stool accumulation. The rectum can become distended. You can actually get decreased sensation in the rectum as well, which obviously would perpetuate the problem. It can happen in adults as well. There's a disorder in particular called dyssynergic defecation, which is like a learned pattern of pelvic floor dysfunction. You can also just have more straightforward holding of stool due to anxiety, trauma, or access issues. I assume that means access to a bathroom, plumbing. The whole mechanism of that's pretty interesting. If somebody's habitually holding their stool for whatever reason, it kind of disrupts the cycle of having that natural urge to defecate. Obviously, stool accumulates in the rectum. The longer it sits there, the more water gets absorbed from it. So, of course, that makes it harder and bigger and difficult to get out. The rectum over time will actually stretch to accommodate larger volumes of stool, and it becomes desensitized. So then you can't feel the urge, and then you don't go even more. And over time, you get this cycle where just the normal tone of the rectum and its ability to create motility become impaired. And you end up getting an overflow situation like we talked about before. In kids specifically, they call that encopresis, meaning that you have soiling or leaking of stool after a child has been toilet trained. And one can see how that would create some psychological distress and interfere with the whole process even more. And then the last kind of set of issues under the pathogenesis bucket would be dietary and lifestyle. So not getting enough fiber in your diet, not taking in enough fluid, not moving around a lot. I feel like those things are a big contributor to constipation. And I'm going to guess the majority of patients who don't have some kind of underlying disease. Obviously, medications, the big one would be opioids. And now more recently, we're seeing this a lot with the GLP-1 medications. I think it's good to encourage your patients on, especially opioids and GLP-1s, to be aggressive, proactive to keep the constipation from happening. Of course, with opioids, there are specific medications you can use to treat that type of constipation. I'm thinking of methyl naltrexone, brand name Relistor. I've tried to use that a few times and generally run into a cost issue with it. I don't know if I've had anybody that I've been successful in getting on that regularly. Other medications that can cause constipation: anticholinergics, calcium channel blockers, iron supplements. Iron is a big one. And some of the antidepressants. I wouldn't really think of an antidepressant as causing constipation, but some of them do have anticholinergic properties. And we have serotonin receptors in our GI tract. So if you're messing around with serotonin, they can potentially affect the gut as well. The worst offenders probably are the tricyclics. So amitriptyline, nortriptyline, doxepin. Some SSRIs can cause this. Paroxetine, brand name Paxil, is one of the most likely. Less commonly, sertraline, fluoxetine, citalopram, and escitalopram. With the SNRIs, venlafaxine and duloxetine can both do this. Not as much of an issue with the atypicals like mirtazapine and bupropion, but they can cause it. Other medical conditions can contribute to constipation, so hypothyroidism, that makes sense, diabetes, Parkinson's, IBS. Of course, there's a constipation predominant version of IBS, or those people can kind of alternate back and forth. And any kind of structural issue of the colon, of course. So colon cancer or rectal cancer would be the scariest things there. Rectal prolapse, anal fissures can contribute to this. Diagnosing constipation you'd think would be simple, but it is challenging. You have to really kind of drill down on people's bowel habits as much as we love talking about poop all day. So you want to try to get as detailed a history as you can and really get an idea of what people mean when they say, oh, it's fine, it's normal. A lot of times the family members will kind of tell on people when they try to blow past that. You can ask about straining, like, do you have to work really hard to have a bowel movement? I think most people, if we're talking about that, are going to report that themselves, but maybe not. Obviously, we have to look out for any red flags like weight loss. We already mentioned sudden change in bowel habits. Of course, blood in the stool always merits a workup, whether that's frank blood, aka hematochezia, or dark tarry looking stool, aka melena. It's always nice to know about family history as well. If all the siblings and all the parents have colon cancer, then obviously the index of suspicion is going to be higher in those patients. You might be a little more aggressive about pushing them to go see GI and get a colonoscopy, even if they are younger than 45. There are formal clinical criteria for stratifying constipation. That would be the Rome 4 criteria. That's actually a much broader system that's used to diagnose all kinds of functional gastrointestinal disorders. I can't say that I've really used this in practice. Maybe this is more of a thing if you're a GI person and you need to worry about insurance coverage of whatever procedure you're thinking about doing. The actual specific criteria for functional constipation are 2 or more of the following: straining during more than 25% of defecations, lumpy or hard stools in more than 25% of defecation. Of course, we have this lovely Bristol stool scale that you can use to kind of, I cannot help but laugh at the Bristol stool scale. If you need very, very specific information about what type of stool someone is seeing, it is quantified in the Bristol scale. There's type 1 through type 7, and you can look that up yourself. I'm not saying those words. Back to the Rome criteria: sensation of incomplete evacuation in more than 25% of defecations, sensation of anorectal obstruction or blockage in more than 25% of defecations, manual maneuvers to facilitate more than 25% of defecation. People will tell you in great detail how they go about manually disimpacting themselves, which I feel really bad for people having to do that. Doesn't mean I want to hear about it, but that does give you a clue that, hey, this is really serious if somebody's having to do that. Of course, the fewer than 3 regular bowel movements per week. Loose stools are rarely present if you're not using a laxative and you don't meet criteria for IBS. So there's your Rome criteria. As far as diagnostic tests, hopefully this is a clinical diagnosis. Hopefully you don't have to do too much else to figure it out. I'm starting to do more abdominal x-rays in the office, just KUBs, upright abdominal x-rays. I'm tired of sending people for CT scans just to learn that they're constipated. If someone really is backed up, you can oftentimes see that on an x-ray. If you're looking for underlying causes or complications, obviously you want to check the thyroid, the serum calcium level, and electrolytes to look for any imbalances there. If you're worried about bleeding, of course, you can do a hemoccult test. You can check the CBC and hemoglobin levels to see if they're really losing a significant amount of blood. CT scan will definitely show constipation. I think you get a lot of bang for your buck with the CT because that's going to show you a whole bunch of other things as well. I try not to jump to the CT scan because it's not the end-all be-all. It's certainly more expensive than an X-ray, and it's certainly a lot more radiation. So I do try to be a little bit conservative with ordering CT scans on everybody. I will often do abdominal ultrasounds if there's nothing in particular that I'm looking for, if I have a low index of suspicion that I'm even going to find anything. But I think if you can figure out it's constipation with just your history and physical exam and maybe the abdominal x-ray, that's kind of the ideal situation. If you have a more complicated situation, you can send the patient for colonic transit studies or defecography, specifically in situations where you have a slow transit issue or pelvic floor dysfunction. There's anorectal manometry, where they actually measure how much pressure the sphincter is able to apply. And there is rectal sensory testing. So if there's a situation where the rectum has lost some of its sensation, they can pick up on that. I have a couple of patients, at least, that I know have had the anorectal manometry. I don't know that I've ever run into anybody that had the rectal sensory testing, or maybe I'm just not aware of it. That might not be something you run around telling everybody about, I guess. So what do we do about it? Ideally, we can fix it with dietary and lifestyle changes. So we want people to eat more fiber. They can do that by increasing their dietary intake, fruits, vegetables, whole grains, and or they can take fiber supplements. I always recommend the soluble fiber like psyllium, brand name Metamucil, because it's helpful either way. That can help with constipation and diarrhea in certain situations. So I always recommend that. Hydration is a big thing. Obviously, we want people to drink enough water and we want them to move. The more people move and exercise, the better it is for their colon and, everything else too. So you pretty much never go wrong recommending more water and more exercise. There are a bunch of different kinds of medications that we can use. It's a little bit misleading to just tell somebody to take a laxative because there are several different mechanisms and several different options for that. Of course, with the fiber, you're aiming to just create more bulk, right? So that it will stimulate more moving along of the colonic musculature. And that also helps increase the water content of the stool, which helps things move along. We have stool softeners. Docusate is the one I typically use. When we talk about true laxatives, we're talking about osmotic laxatives. So that would be like polyethylene glycol, brand name Miralax, lactulose or sorbitol. Those work by just pulling more water into the colon. And those are fine to use all the time. Usually our local GI doctors will tell people to take Miralax and fiber every day. And some people require that. Some of our newer options are the guanylate cyclase agonists. This is linaclotide and plecanatide, brand names Linzess and Trulance, respectively. These kind of work like osmotic laxatives a little bit in that the goal is also to increase the amount of fluid secreted by the intestine, but it also works to increase motility as well. You have lubricant laxatives, primarily mineral oil. Those can be helpful for short term, not necessarily recommended for long term use because they can interfere with absorption of some of the fat soluble vitamins over time. We have prostaglandins. Most common example would be lubiprostone, brand name Amitiza. Misoprostol is also a prostaglandin that can be used for constipation. I'm going to admit that I didn't know that. That is an off-label indication according to Hippocrates. So if you have a patient that needs to be on Trulance but can't afford it, maybe you could do misoprostol instead. This also affects that guanylate cyclase. C, it's an agonist, so it also works to increase intestinal fluid secretion and motility. We have serotonin receptor agonists. These would be prucalopride, brand name Motegrity, and tegaserod, brand name Zelnorm. Zelnorm was withdrawn from the U.S. market in 2022 by the manufacturer. The other one, I guess, is still around, the prucalopride. These actually serve to stimulate peristalsis and increase motility by binding to that serotonin receptor. I'm pretty sure I never heard of that. I saved the best for last are stimulant laxatives. I did a whole episode on stimulant laxatives a while back. There are many examples of these. I guess the common ones would be Senosides and Bisacodyl, sold under a whole bunch of different brand names. Castor oil also fits in this category. These work to just encourage the colon to move things along. In my episode, I talked about whether or not these are safe for long-term use. The classic teaching has always been you don't want to use stimulant laxatives regularly for a long time because you become dependent on them. But it seems like there's actually some question about the evidence for that. So I've been a bit more liberal about telling people to use stimulant laxatives lately. One thing that stuck with me from a Curbsiders episode about constipation was the guest was saying you need the mush and the push. One without the other is not as helpful. So that's kind of how I think about it when I'm talking to patients. So if you're talking about stool softeners and osmotic laxatives, those things would create more mush, right? Make the stool softer. And then the push is your stimulant laxative. So it's good to use those in combination, at least when you're talking about an acute situation. And I definitely encourage people to take fiber and stool softener and osmotic laxatives on a regular basis just to keep things moving. And then I already mentioned the methyl naltrexone for opiate-related constipation earlier. There are behavioral interventions you can implement for this, including pelvic floor biofeedback. I think that was a big one that they discussed on the Curbsiders. And then just bowel training, kind of help people create a set routine or a set schedule for using the bathroom. Some special considerations in different populations with elderly people. Of course, we got to watch out for polypharmacy. We're throwing all these medicines. We got to think about frailty. We got to think about dehydration. We got to think about not wanting to make them get up during the middle of the night if we don't have to. Boy, that whole situation is tough. I deal with a lot of elderly patients, and it's such a tenuous situation, right? It's so difficult. You read your textbook, you read the Beers list, the Beers criteria, and you're like, heck yeah, I'm taking all my elderly patients off of all these medications. But guess who needs those medications? Guess who really needs all those medications many times? It's the elderly people. So, man, it is so hard to find the right balance of let's use some common sense and treat what needs to be treated versus let's try not to kill you with all these medicines. It's a tightrope. It's a big time tightrope. With pregnant patients, obviously you want to focus on fiber lifestyle changes. We prefer to stay away from the stimulant laxatives and osmotic laxatives with pregnant folks, although you can use them if you need them. But if we can address the constipation in other ways, it's preferable. Kind of the same thing with pediatric patients. You want to go easy on the medicine if you can. Dietary changes, adequate fluid intake, stool softeners if you have to do something before you move on to any kind of laxative. We definitely try not to use stimulant laxatives in young kids like under 6 if we don't have to. When to refer, if you can't get it under control by yourself, that's always a great reason to refer to a specialist. Obviously, if you have any big red flag symptoms, if you think there's something like IBS going on that's more than just functional constipation, or the people who truly have motility disorders or pelvic floor dysfunction, they definitely need to go see GI for more of a specialist evaluation of that. So yeah, I think that's probably about all there is to say about constipation. I feel like I have definitely gotten better at recognizing this and managing it over time. A lot of times the typical scenario that happens in my office is we have this conversation. I think, I wonder if they're constipated. Get the x-ray, the upright abdomen or KUB x-ray. Lo and behold, it looks like there's a bunch of poop all backed up. A lot of times it's like pretty impressive. It'll be all the way around to like the ileocecal junction sometimes. And you're like, how are you not just absolutely miserable? And I will encourage the combination of osmotic laxative softeners and stimulant laxatives. Sometimes I'll just go for it if I'm really not worried about causing any kind of rupture or anything. I'll just prescribe Go Lightly like I would for a bowel prep before colonoscopy. I don't know if people really do it as aggressively, but that will typically clean them out. Sometimes I'll do lactulose instead. And my anecdotal experience with the Linzess especially is that a lot of people can just use it as a PRN medication. Obviously, the intent is to take it as a daily medication, but I find a lot of patients will stop it because it works kind of too well. So I have a lot of patients that end up just using that as needed. Or if you have samples on the shelf, you could definitely give somebody a sample and have them just use it to try to clean out, particularly if you have that higher dose, the 290 available. So yeah, there you go. Hope this was informative and helpful. Of course, thank you for listening. Special thanks to our Patreon supporters. Please let me know if you have any feedback or if you have any suggestions for topics to cover as we go through the alphabet here. I don't have a plan for D yet. I'm not sure what I'm going to do on that. We've covered diabetes multiple times, so I don't know. I've been thinking about that one. Hey, I hope you have a good week. Be sure to take your fiber and get plenty of exercise and drink plenty of water. Here's hoping you have at least 3 bowel movements before you hear the next episode. We'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.